let us begin. We're going to begin our first parallel session of Tuesday in virtual room 1, which they have labeled as equity. So the first speaker we have today is Khadija, who will be speaking on the distribution of urban healthcare facilities in Bangladesh, findings from a health facility mapping study. Please go ahead anytime you're ready.
Thank you, Tiffany. I will just share my screen and start it. Please let me know if you can see my screen.
Yes, thank you.
Okay. Can you see it?
Yes.
Okay, thank you. Then I'll go ahead. Good afternoon, everyone. It's actually afternoon in Bangladesh. I'm Dr. Khadija Islam Tisha, a public health researcher from Bangladesh, currently working as a research physician at International Center for Diarrheal Disease Research, Bangladesh. I welcome you all in today's presentation. The world at present is mostly urban, with a greater proportion of people living in urban areas. Like many other low and middle income country, Bangladesh is rapidly urbanizing. The share of the urban population has risen from 24% in 2000 to nearly 39% in 2021, which is estimated to rise to 56% by the year 2050, according to the most recent projections. Living in urban areas can be both promising and perilous for health and well-being. The rapidly expanding urban population has placed an enormous strain on the urban healthcare delivery system, which often jeopardizes the harmony between the supply and the demand. Similar to most South Asian countries, Bangladesh has mostly focused on rural health policy and provided less attention to urban areas. This leads to a lack of credible data required to inform decision making around the urban health planning. As a consequence of this imbalance, inequities in healthcare provision amplify. However, inequities in healthcare distribution concerning the rapid growth of the urban population has often overlooked. Sorry. As a consequence of this imbalance, inequities in healthcare provision amplify. By analyzing health facility mapping data, we aimed to explore the gaps in the availability of healthcare provision proportion to the city size. Now move on to the method section. The study was conducted in from 2014 to 2017 in 6 cities of Bangladesh. The study has conducted in 2 stages. In the first stage, the health facility were surveyed and listed using the geographic information system. And in the second stage, the healthcare facilities with the formal healthcare facilities with that provide a wide variety of services have been surveyed using a survey questionnaire, and then the data was analyzed following the data cleaning. In this study, we have categorized the 6 cities into 3 groups: small city, medium city, and large city, based on the population and the governing authority. Here we considered Dhaka and Chattogram in large city, and Rajshahi and Khulna as medium city, and Dinajpur and Jashore as small city. Now move on to the results section. Geomapping from the study showed that health facilities are well distributed at the throughout the cities. At first glance, it appeared that large cities have a higher concentration of healthcare facilities in compared to the medium cities and small cities. If you can see the maps, the healthcare facilities have been showing higher concentration in these cities. Large city, it actually gradually decreasing in the city sizes. Medium city have a fewer concentration of a less concentration of healthcare facilities and much less in small cities. With an aim to gauge the magnitude of before mentioned disparity in healthcare distribution of Bangladesh, we have done some simple descriptive analysis where we found a different scenario. A rising trend of healthcare facilities according to the growing city size is seen in this graph, but here we did not consider the population need. However, the picture actually turned upside down when we compared the facilities in relation to population demand. Here you can see small cities have an average of 4.4 public facilities per 100,000 population, while large cities have only 1.4 and medium cities have 2.7. Similarly, the small cities have 82.8 hospital beds allocated for per 100,000 population, while large cities has only 28, which is evidently insufficient for the population. A similar declining trend is found among the healthcare professionals' density or number. In this case, we considered physician and nurse as healthcare profession. The number of the number of physician is also declining according to the city size. In small cities, they have 464 physician per 100,000 population, while large cities have 280. Similarly, large cities have an average of 130 nurses per 100,000 population compared to 2012 in small cities. The number of healthcare professional that has been shown in this graph will be much less than the actual number, as in low middle income countries dual practice is a common trend. But this is a limitation of our study. We did not we did not consider the dual practice. The findings of this study shed light on an overlooked issues of urban health. We try to see urban health through an equity lens. It highlights the need of redistribution of urban healthcare facilities and resources, focusing on the healthcare demand of the population. This generated evidence will support and drive action in making evidence-based decisions aimed at improving urban health and well-being. Now we have come to close my presentation. Urban areas and services should be redesigned to support healthy cities by placing health and well-being at the center of the city planning and reform. Cities are evolving every day. They provide a chance for us to reform and redesign, but often the health concern is overlooked or ignored in planning of the cities, which should be addressed. And urban health issues, however, cannot be resolved in a silo. We must embrace collaborative accountability across different sectors like public health engineering and also. Thank you, everyone. If you have any question or comments, please, you can contact with me with the mail address provided. Thank you.
Thank you very much. I do have one question, which is, are policymakers, are they aware of this inequity? Or is it something that's still being highlighted through the kind of evidence that you're generating now?
No, it's actually, we're generating evidence on this. Policymakers did not, actually, this equity concern is not well established till now.
Okay. Are the cities just growing too rapidly to support additional movement of healthcare workers? Is that the issue?
Yes, it's the issues as people are migrating from rural areas to urban areas more, but more focus is placed on rural healthcare system. Urban healthcare system is not well developed.
Okay.
To cope up with the rapid urbanization.
Okay. It's really interesting. Does anyone else have any questions or comments? And if you think of any, you can always put them in the chat as well.
Yes.
Thank you.
Thank you.
Right, so let's move on to my presentation. So I'll be talking about air quality perception and acceptance of a clean air zone in a city in the north of England. And I can just... Right. So air pollution is an environmental health risk, with almost all the world living in areas which do not meet the WHO air quality guideline levels. Air pollutants like those from vehicle exhaust, they are known to negatively impact on the health of both children and adults, and they've been linked to a range of health outcomes, including poor birth outcomes, cardiovascular disease, and cognitive development. In the UK, there are over 64,000 deaths a year, which are attributable to outdoor air pollution, with a greater burden of air quality related illnesses in the young, the elderly, and those living in deprived areas. And deprivation is a key predictor in almost any ill health metric you can think of, with more deprived communities being less healthy. In Bradford, which is the city I'll be speaking about today, this is a multi-ethnic city in the north of England, a city which ranks 5th most income deprived in England, where a third of its population live in the most deprived IMD, or income for indices for multiple deprivation decile, has a higher than average levels of ill health in the city. Bradford, like elsewhere, there are entrenched patterns of spatial injustice, with the most deprived areas, which are highlighted here in blue, bearing a disproportionate burden of environmental stressors such as pollution, noise, and lack of green spaces. And in the map on the right here, you can see the red areas, which indicate worsening noise, pollution, less green space, mapping almost directly onto the blue spaces of deprivation in the map to the left. The current UK regulations set the limit of nitrogen dioxide, which is the pollutant formed from the burning of fossil fuels, at 40 micrograms per meter cubed. And Bradford itself has levels of pollution that exceed this legal limit at several locations across the city. Many of these locations being located in inner city areas where the most deprived wards are located and where there are high levels of ethnic diversity and young people. So by improving the air quality in these areas, we would actually therefore help those who are the most affected by air pollution. In 2018, Bradford was one of the 28 local authorities to receive a directive to reduce the pollution in the city as quickly as possible. So our local council developed a clean air plan, which was informed by government guidance, modeling, and consultation with businesses, including bus and taxi companies, as well as communities. And this clean air plan included the introduction of a clean air zone, or CAZ. And in the CAZ, this is where older, more polluting commercial vehicles, here are the ones that are being under concern, they are charged daily fee for entering the zone, which is seen in the boundaries here. These low emission zones restrict the entry of these particular polluting vehicles in the targeted area. And this particular CAZ and CAZs in general, low emission zones, have been identified as a potentially effective way of reducing air pollution and improving health outcomes. But the implementation of these are often controversial, and there have been few studies that have actually looked at the perception and the acceptability of these schemes before they're implemented. And it is important to understand how communities feel about this policy before they're implemented, so that appropriate mitigation strategies can be put in place to ensure that these policies are successful. So in this study, the primary aim was to explore these perceptions of air quality in Bradford, but also to explore the acceptability of the proposed CAZ plans amongst those who live and work in Bradford prior to the implementation of the CAZ. A secondary aim was to explore whether these perceptions of air quality and the clean air zone differed by key social demographic characteristics. So we carried out a cross-sectional survey to explore these perceptions and attitudes. It carried out between April and December of 2021. The study population included those who were 18 and over, who lived in or worked in Bradford. And we actually had two different groups of participants in the study. We had a survey that went to the general public, and we also had a survey that went out to our Born in Bradford cohort. This is a birth cohort that was started in Bradford in 2007 to 2011 and follows over 13,500 children. And we have been following them ever since with other follow-ups. And I'm just going to focus on the Born in Bradford or BIB results today. So we assessed attitudes towards air quality using 3 key questions. What do you think about the air quality in Bradford generally? With responses ranging from very poor to excellent. We asked, how concerned are you about air quality in Bradford? We also asked, how important do you think it is to improve air quality? Our respondents were also asked to rate the acceptability of the Clean Air Zone plans using 3 questions. The first is, do you think the CAS is a good idea? The second is, do you think the CAS will reduce air pollution in Bradford? And the third, asking whether they think the Clean Air Zone will improve the health of their family. And in our results, I'll be showing some descriptives where we describe the attitudes and acceptability, and also some results from our latent class analysis, which we use to characterize our participants on 13 key indicators, including ethnicity, marital status, education, whether they lived in the boundary of the Clean Air Zone, and whether they had a driver of one of the vehicles that would be charged under the Clean Air Zone living in the household. We use the latent classes in generalized linear models to then look at whether certain characteristics of the population were related to air quality perception and acceptability of the Clean Air Zone. So we had over 1,000 responses from our cohort. The majority were female, married, and between the ages of 35 and 44. We had a high ethnic diversity, with 44% identifying as white British and 38% as Pakistani origin. About a third were highly educated or in professional occupations, while nearly half were living in the lowest 2 quintiles of Bradford-specific index of multiple deprivation. And about 1 in 9 households had someone who had an occupation where they drove a vehicle which came under the CAS conditions, and almost a quarter of our respondents lived within the Clean Air Zone. When we look at the perception, few thought the air quality in Bradford was good, and only 10% were not concerned about Bradford's air quality. The majority also thought that it was important to improve the air quality in Bradford. And in terms of the support for the Clean Air Zone, nearly 3/4 thought that it was good, that they should be implemented, although 30% did not, and this is still a pretty significant number. Almost half of those thought that the Clean Air Zone would reduce pollution in Bradford, and actually only about a fifth thought that it would not reduce air pollution, and 2/3 of our respondents agreed that the Clean Air Zone would improve the health of their families and community. In our latent class analysis, we identified 3 classes. The first class, having 25% of our respondents, were mostly white British, less educated single women who worked in semi-routine or routine occupations. 29% came from the most deprived areas of the city, and 11% lived in the Clean Air Zone area. And we can characterize these as the single lower SES white British. The second class was 31%. They were mostly married white British women who worked professional occupations and had relatively good financial status, so they lived comfortably. And 11% of them lived inside the CAS area. The third class was 44% of our participants, and they were mostly married Pakistani women who worked in non-professional occupations, with 29% coming from the most deprived area of the city, and more than half living inside the boundary of the Clean Air Zone. And this group also reported the highest number of people who drove one of the vehicles that came under CAS conditions among the groups. So when we looked at our models, comparing our different classes here, we've got our single lower SES white British and married higher SES white British compared to a reference group of married lower SES Pakistani origin women. And here we also compare between these 2 groups, with the married higher SES white British women compared to the lower SES white British women. So what we find is that compared to our reference group, the single lower SES white British women and the married higher SES white British women were less likely to say that air quality was good or excellent. The married high SES white British women were also less likely to say that air quality was not a concern compared to the other 2 groups. When we talk about the CAS, we found that our married SES white British respondents were twice as likely to agree that the Clean Air Zone was a good idea, was acceptable compared to either groups. Our single lower SES white British women were also less likely to say that the CAS would improve the health or reduce pollution compared to our reference group, while our married higher SES white British women found that these were more likely to say that it would improve health or reduce pollution. So really, our survey really indicated that the residents of Bradford City, they recognize that air quality is not good currently, and the majority of our participants felt that its improvement was essential. Many of them acknowledged that the benefit of the CAS and they support its implementation, but we did find that there were differences in perception based on key social demographic factors, with weaker support among our Pakistani or lower SES white British communities. These analyses showed that our Pakistani families who live in areas of high deprivation and who are more likely to have drivers of taxis, vans, or lorries, and to live in the clean air zone boundary, felt that there was less of a problem with air quality, and they were less supportive of the clean air zone. Our lower SES white British communities also held similar views in terms of support for the CAS. On the other hand, our higher SES white British families who lived outside the zone, the clean air zone, were more supportive of the clean air zone and also were more concerned about air pollution. A lot of the narrative around social justice in relation to low emission zones suggests that families living in areas of higher pollution would benefit the most from having one of these implemented. Our findings show that families who live in the most deprived areas were actually less likely to support the clean air zone, and they were less concerned about clean air and air quality as a whole. And again, these families are the ones who report the highest numbers of drivers of taxis, vans, and lorries who would incur a charge if they entered the zone. Previous research that we've conducted has shown that these communities, for them, pollution is often a hidden issue, and they're not prioritized over other environmental burdens. And so the extent to which air pollution is a priority for these communities can influence how ready they are to accept a policy like the clean air zone. So what our findings suggest is that it's important to tailor messages to different communities about the reasons for implementing policies such as the clean air zone, and that they should communicate the proposed benefits and policies to ensure that community concerns are addressed, to really ensure that the success of the policies can go on. And thank you very much for listening, and I'm happy to take any questions or comments that you might have. I will stop sharing now.
Really interesting presentation. I enjoyed it.
Thank you.
Just turn on my video. Yeah, extremely interesting, Tiffany. Thank you very much. I guess my question or comment would be: were you in any way surprised? Because it seems, I mean, I do lots of poverty-related research, and it does seem to me that those people who have an economic stake are most often the ones who, in spite of the kind of harsh realities of climate change and pollution, are the most likely to continue to deny the reality and its impacts simply because their livelihoods depend on it. Any comment or thoughts?
I suppose it wasn't, I don't know if I was surprised or not, because there was a lot of messaging from our local government about the clean air zone, the benefits, it coming into place. But I think maybe what this highlighted is that we needed, or the council needed, more targeted approaches with these communities. Mm-hmm. You know, they did hold consultations, and we did speak to, as part of the research side, to communities that are often less heard. But I think there was still a lot of concern about what this would mean for businesses, because we have a lot of taxi drivers and lorry drivers and whatnot in these communities that are most affected by air pollution and where the zone is coming into place. And we did do some qualitative work as well. And I think there was just a bit still, the zone is in place now, but even now you still hear, leading up to it, confusion about who was going to be charged. A lot of people thought passenger cars were still going to be charged, even though that's not the case. So I think this really highlighted that you can't necessarily have a general communication campaign. It needs to be, you need to know who is not receiving the message you want them to receive, and to go in and be able to ensure that their concerns are heard and met and explained.
Right. Yeah, no, that makes sense. I mean, so often political messaging is one blast oriented to everybody, and that doesn't work. Yeah, really interesting. Thank you.
Thank you very much. Right. Well, let's move on to Saloni Dev, who will be talking to us today about spatializing Stigma-Power, mental health impacts of spatial stigma in a legally excluded settlement in Mumbai.
Thank you, Tiffany. And thank you, Tiffany and Khadija, for your wonderful presentations before. I hope you're able to see my screen.
Yes, great.
Awesome. So a very good morning again to all attending the session today. My name is Saloni Dev, and I'm an assistant professor in the Department of Public Health and Community Medicine at Tufts University School of Medicine in Boston, USA. And today I'm going to present findings from our qualitative study looking at the mental health impacts of legal exclusion in an informal settlement in Mumbai, India. So let me first introduce you to Kala Bandar, which is a slum settlement on the eastern waterfront of Mumbai. It is located on a wharf and approximately houses 12,700 people. It is a non-notified slum, which means that it is not legally recognized by the government and hence suffers a substantially poorer access. Oh. Sorry, my PowerPoint just decided to sleep.
Oh, can you restart the program?
Yes.
Okay.
Yes, I am. Just give me 1 second. Sorry about that, everyone.
That's all right.
It's
all
the
right,
plus of a small audience.
All right, I'm back at it, and I'm going to reshare my screen. My apologies, technical difficulties.
It's all right. It happens a lot.
All right, once again, we try.
Great.
All right, I think, yes.
All good.
All right, so I was talking about how Kala Bandar is non-notified, which means that it is not legally recognized by the government and hence suffers substantially poorer access than notified slums to toilets, piped water, electricity, etc. And they also receive much less assistance from government slum improvement plans. And let's go through my animations. So of note, a higher prevalence of common mental health disorders has been previously reported in Kala Bandar. And deprivation in access to basic services and unequal access to opportunities in Kala Bandar have been found to be associated with psychological distress and probable common mental health disorders. With this setup, I would like to draw your attention to geographic disparities in health that have been previously noted globally, with disadvantaged low-income neighborhoods experiencing the worst health outcomes compared to advantaged and affluent neighborhoods. And underlying the impact of these factors on health disparities are acts of systemic discrimination that impact the uneven distribution of resources, education, and employment opportunities within and between localities. And this discrimination often stems from the stigma attached to particular geographic locations, which creates perceived distinctions between acceptable and unacceptable neighborhoods. Now, this stigma attached to particular spaces, or spatial stigma, as a symbolic dimension of systemic discrimination, shapes residents' experiences of their lived reality, and thereby their mental health and well-being. However, it remains underexplored in public health research. And in this study, we aim to investigate the extent to which stigmatized perceptions of Kala Bandar may help explain the high prevalence of common mental health disorders among its residents. So to study this, we reanalyzed qualitative data that was initially collected in Kala Bandar to inform the development of a slum adversity index. Local youth researchers from Kala Bandar, trained by our collaborating organization, Pukar, conducted 40 individual interviews and 6 focus groups with a purposively sampled group of Kala Bandar residents. And the interview participants included an almost equal number of women and men, and 1 transgender participant, while there were a total of 46 focus group participants. And we used a thematic analysis with a deductive approach to analyze the data. And pathways between spatial stigma and health identified a priori from a comprehensive review by Jamie Pierce, served as a guide to our analysis and to our understanding of the association between spatial stigma and mental health in our samples. So what you see here is the model that guided our analysis. These are the 5 pathways relevant to spatial stigma and its impact on health, as summarized by Jamie Pierce. And Pierce emphasized that structural forces produce spatial stigma in the first place. He also identified that a spatial stigma impacts mental health of residents of a stigmatized space through disinvestment in public resources, internalization of spatial stigma, weakened community solidarity, and unequal access to opportunities. And as I said earlier, we used this model to identify if we could find evidence for any of these pathways in our data. And I would like to highlight that we did find evidence to support all these pathways in our data and some more. More importantly, we found that structural forces independently influence disinvestment in infrastructural resources to achieve the goals of eviction and clearing up the land that Kala Bandar occupies. In addition, our participants reported internalizing spatial stigma enacted through disinvestment and discrimination against them. And lastly, internalization of spatial stigma also directly impacted community solidarity as residents tried to push stigmatizing perceptions onto their neighbors. And I'll walk you through each of our findings separately. So first, we're going to take a look at this section of the visualization. Our data suggested that political processes may construct spatial stigma over time, primarily through exercising what is known as Stigma-Power, which is a form of power or resource that helps the stigmatizer achieve their ends by keeping those being stigmatized down. So Stigma-Power was actively utilized by public authorities in the form of social disinvestment and collective punishment, including raiding of water motors, cutting electricity wires, neglect of garbage removal, and releasing stray dogs, to name a few. And these actions had important symbolic dimensions by enacting stigma and shaping perceptions of KB or Kala Bandar as a stigmatized space. And these practices further marginalized Kala Bandar residents through inaction by the public authorities, such as the police, as explained by one of our participants, who said the electricity and water problems exist all across Mumbai. Compared to the rest of Mumbai, we do face somewhat greater problems with water and electricity, but the police harass us much more than people in other communities. The police always takes bribes from us. They ask for 40,000 rupees. What will I give to my children if they take that kind of money from me? How can we be without tension in this situation? And this shows that navigating such infrastructure deficits forced many residents to carry an undue financial burden, such as, when their water pumps got raided, that dramatically increased their water costs, thereby pushing the families further into poverty, leading to negative impacts on their mental health, described using the word tension, a term that is routinely used in India to indicate psychological distress. Now, our findings also revealed the impact of spatial stigma on residents' identities. They expressed awareness and acceptance of others' stigmatizing perceptions of Kala Bandar and feeling shameful of their neighborhood. Some residents further highlighted their acceptance of such perceptions as true and valid, and often viewing themselves as well as Kala Bandar through such a negative lens. So, for example, one of our participants said, I think all the time that I'm not a part of the city. We have our names on the voting cards, we go out to vote, but look at the conditions of our area. It does not look like the rest of Mumbai. I feel like people treat us differently. They don't consider us a part of Mumbai. And this person concludes saying that she and others live in garbage. And the effects of internalization of stigma can include a decrease in self-efficacy and self-esteem, which has been reported to be a risk factor for social disorder and mental illness. Our findings further underscored that internalization of spatial stigma undermined community relationships. Residents distanced themselves from other residents and claimed that the stigma attached to Kala Bandar applies to their neighbors, but not to themselves, a process actually known as lateral denigration, whereby residents of a stigmatized neighborhood actively redirect stigma towards their neighbors to distance themselves from the spatial stigma associated with their neighborhood. So this person pointed out that the poor conditions in Kala Bandar could actually be ascribed to others living there who do not throw trash in designated spaces. And this actually was at odds with the reality of the neglect of solid waste collection in Kala Bandar. And residents utilized the strategy to manage or minimize the personal stress or shame associated with the stigma. And lastly, many of our participants suggested that the community is discriminated against by local administrators and the police and the residents of the other parts of the city. So one of our participants said, currently I'm not employed. I have been looking for a job, but no one is willing to give me a job once they hear that I'm from Kala Bandar and that I'm a Muslim. This has irritated and frustrated me a lot. And in addition to denial of employment opportunities, other instances of discrimination included denial from taxi drivers to come to Kala Bandar, and also thinning of social ties in the community. So overall, our findings support the small but growing literature on the role of state actors and agencies in the construction of spatial stigma, and it provides initial evidence of this phenomena in Indian informal settlements. And we recognize the immediate need for future studies to develop a measurement tool for spatial stigma that would allow for quantitative examinations of its impact on mental health. And a longitudinal analysis in the future, in particular, could help provide evidence for causality and the underlying pathways that we outlined in the study. And with that, I'll wrap up my presentation, and thank you all for this opportunity again.
Thank you very much. That was really interesting. Does anyone have any questions or comments? I've got one.
No question, but I would certainly echo the interest. I've kind of haven't really done very much reading on spatial stigma, but it's an extremely interesting concept. And I do a lot of work on kind of with single mothers who are live in poverty, and it's very relevant for many of the neighborhoods in which they live. So thank you very much for that.
Thank you.
Yeah, it's again, I've never heard of this term before, but I'm going to have to do some reading. But I wanted to ask, what is the relationship between sort of spatial stigma and the role of gentrification?
I think there is indeed a relationship. And, you know, especially in our analysis and the literature review we did for the study, we really found that spatial stigma really, and also the concept of Stigma-Power, which is when, you know, people who stigmatize others use stigmatization as a resource to keep others down for their own good or for their own advantage. And, you know, I think it's a bi-directional relationship when we think about gentrification or, you know, redlining or all of these things that divide neighborhoods very systematically and, you know, induce systemic discrimination. And there are definitely there is intent to keep certain areas, you know, in a specific way or gentrify them or keep them, have them be better than other areas. That could, you know, increase the inflow of employment opportunities or educational opportunities in a more relative way. So it's definitely, you know, there's a vicious circle going on there when we think about geographic, or something like, I think I should use the example of gentrification of cities or neighborhoods, if that answers your question.
Yeah, it's just interesting, the shifting sort of landscape of what's considered a stigmatized area to live and what happens when it becomes gentrified and prices out people who were living there with influx of different people and different groups. Yeah, it's just really interesting. It changes the sort of identity of a place and who belongs.
Exactly. And it starts with stigmatization. And, you know, as also we saw in the case of Kuala Bandar, one of the goals is to clear up the land, because that land where Kuala Bandar sits, it actually belongs to the state, to the central government or the federal government. And, you know, once it's cleared up, there are so many opportunities that open up for economic development or construction. And how that changes, as you said, the landscape and, you know, the meanings and perceptions attached to that space over time.
Really interesting. Thank you. Okay. Next up, we have Lea, who will be presenting single mothers and affordable childcare, small policy steps to improve gender equality and positive health outcomes.
Thanks, Tiffany.
Great.
So good morning or afternoon or whatever it may be for all of us. So I'm Lea Caragata. I'm a professor in the School of Social Work at University of British Columbia, located in Vancouver, on the traditional and unceded lands of the Musqueam people. And I'm going to talk, and I'll move through this fairly quickly because we don't have a lot of time, but I'm talking about the rollout in Canada, finally, after many, many promises, of a $10 a day childcare provision. And for some of you, probably not for somebody in Boston, but maybe in the UK, childcare is essentially inaccessible for people, even middle class people. It can cost up to $1,600 to $1,800 a month. And so single mothers, as the slide suggests, comprise about 85% of single parents in Canada, more likely to live in low income than any other population group. And no surprise to the women around the table, as it were. Their primary custodial obligations when families break up, combined with the fact that there continues to be a gender pay gap, means that they are far more likely to live in low income. And finally, in Canada in the last year, both federal and provincial governments have begun to roll out $10 a day childcare. So a promise of it, it's rolling out slowly, but this research looks at the impact of these new childcare provisions on the health of the mothers. So as you can imagine, there's lots of attention to how affordable childcare and good licensed childcare is going to impact kids, but there's been very little attention to what it means for somebody who's a single parent living in low income. So the methodology, we use a participatory action research methodology. We hired 7 single mothers living in low income and trained them as peer interviewers and research associates that are involved in all aspects of the research. And we conducted interviews with low income lone mothers accessing those $10 a day childcare sites. The criteria for inclusion included having a child 0 to 5, living all across the province, the vast province of British Columbia. And the interviews were done both in person and using Zoom. And this is preliminary data. Our study is continuing. So just a few demographics, and I'll go through these pretty quickly. We had about in the order of 75% white Caucasian women and about 20% Indigenous racialized women. Most of the women were between the ages of 29 and 38, not surprising given the ages of the children. And most were employed between full-time and part-time. Very few were not employed at all. So the childcare is available to people who are not working full-time, but it was critical for us to look at what it really means for people who are attached to the labor market and trying to kind of balance and challenge cope with the challenges of being a single parent and working full-time. So theoretically, we look at the research through a kind of intersectional feminist lens. And in examining health, we're thinking about it broadly through a social determinants of health lens. And so obviously we're thinking about health in terms of it being constituted by quite a range of social and structural factors: income, education, neighborhood, physical environment, and social networks. The interviews asked about all of those realms. And we also wanted to really acknowledge theoretically as well that those marginalized statuses, including racialization, disability, often intersect with low income, with lower levels of education, poorer housing conditions, and more limited social networks. So we're seeing a whole kind of confluence, if you will, of challenging circumstances for the parents who we're interviewing. And in Canada, I think it's probably important to note that most single mothers are single mothers by reason of family breakup. Unlike, for example, in the United States that has a significant issue with teen pregnancies, those are much, much less common in Canada, partly because we continue, I'm sorry to mention this difficult subject, Saloni, but mostly because we continue to provide good family planning information and accessible birth control. So really single mothers in Canada are generally the custodial parent after families break up. So that's an important acknowledgement. So in terms of thinking about our findings, we've identified 3 major themes: improved mental health, better parenting, stronger and more secure labor market attachment. And that, of course, relates to less income stress. So in terms of this particular conference and its focus on health, I think the most important finding is probably the health and well-being effects, which were quite profound. The ways in which the women reported these were with real feeling that finally they were able to kind of have moments to, as the slide says, practice self-care, to work out, to exercise, and they were less stressed because of the childcare costs now being diminished. Many women were struggling to even be able to kind of afford in the most basic way childcare. And so the consequence of that was that the childcare costs deprived them of all of the other kinds of disposable income spending in their households. They talked about reducing their stress because they could manage their job better. One woman talked very poignantly about being able to buy better quality food, that she could buy fresh fruits and vegetables, which she couldn't afford before. Other people talked about the fact that their children were in healthy, safe environments. One of the women that we interviewed talked about prior to the $10 a day childcare, she couldn't afford a licensed childcare facility. So her kids slept on a neighbor's couch overnight while she worked nights. And she was never sure about the care they got. They obviously didn't have the kind of usual bedtime regimes that lead to healthy outcomes for kids. So having kids in a healthy, safe environment reduced maternal stress in a huge way. And people talked about being less time and money constrained. And one woman talked very poignantly about the fact that it allows me to have my own identity, not just as a mother. I want to keep working, retire at a reasonable age. This person wanted to kind of be someone in their life and not only be involved in kind of caregiving. That was obviously important. So impact on parenting, and obviously if children are well parented, there's lots of research that demonstrates that leads to better outcomes for those kids. So people talked about being able to spend more time with their kids because they didn't need to work extra hours or have an extra part-time job in order to afford childcare. Being less stressed made them more patient with their children. And other women talked about the fact that their kids were less stressed. Everyone's eating better. I don't spend so much on childcare. And somebody very simply says, my kids are happier, I'm happier. And another woman said, it allows me to bring my best parenting game to the table when he is with me, speaking of her son. So the $10 a day and changes to daily life, without it, I couldn't go to work or school. There's extra money to pay for other expenses, activities for my kids, auto repairs. And if we think about activities for one's kids, I kind of return to the social determinants of health and the importance of kind of being able to build social networks and have that kind of engagement in community, which often requires income of some sort, even if it's just income for transit. Another woman talks about we can think about moving, and this picks up on the whole kind of spatial stigma and the issues of kind of poor neighborhoods. My neighborhood is dangerous. I'd like to move closer to my family, but it's never seemed possible because it would be more expensive. So obviously there too, a move would mean enhanced social networks for this mom. And somebody else talks about I can hire a sitter on the weekend to see friends, engage in social activities. And finally, it's given me space to be more grounded and more present, which is obviously critical characteristics of good parenting. So it's not exactly resolved yet. The spaces are still rolling out very slowly because this is a massive expenditure for both provincial and federal governments. So there are still long wait times. And many of the mothers we interviewed continued to talk about the hours of operation being a challenge. Obviously, low-income women don't necessarily get to pick their work hours. They're not working 9 to 5 on regular schedules. And daycares continue to operate from roughly in the order of 7 in the morning until 7 at night. So that doesn't suit lots of work hours. And the real issue with lack of continuity, so that spots aren't guaranteed as kids age. So people put their children in as infants, and then when the kids get to be 18 months, and then again when they're 3, and they need to kind of transition to a next daycare room, and those spots aren't guaranteed. Issues with the illness policy. What do you do with an ill kid without that threatening your own job? So those are only some of the many barriers that people noted, but the most important ones. And so some concluding thoughts. These are very preliminary data, but they evidence the positive impacts of affordable childcare on these single mothers' health and well-being, and improved educational opportunities, stronger work capability, less familial stress, improved parenting, opportunities for improved social connections for both moms and their kids, all point to the likelihood that these families will experience healthier lives. And the reduction in childhood stress, the positive educational and social environments of regulated licensed childcare, and the modeling of a healthier, happier parent will have long-lasting impacts on the kids themselves. Thank you.
Thank you. That was really interesting and also amazing that policy supported this. Was there a lot of support generally, or was there any pushback for this provision?
It has been promised. I don't know what the situation is in the UK, but this has been promised in Canada by successive federal governments for probably 15 years. And the current federal government, without getting too much into Canadian politics, is a Liberal government, but supported, they're in a minority position in Parliament, and they're supported by a Social Democratic Party that has held their toes to the fire and said, we'll continue to support you if you do some of these kinds of things. So in the interest of staying in power, they've rolled this out. It's broadly supported, not by some of the provinces that have more conservative governments, but in British Columbia, we have a social democratic government at the moment that took it up quite happily. So of course there's pushback. These expenditures are going to come from somewhere. Taxes are going to be implicated. But there's the $10 a day isn't restricted to low-income families. Okay. So anybody is benefiting from this. So even for middle-class families, paying $1,500 or $1,600 a month for childcare is extraordinary. And so this benefit works for everyone. And we have a nice model in the province of Quebec. In Eastern Canada, rolled out a $10 a day. Theirs is actually $7 a day, rolled it out about 10 years ago. And it's become universally embraced. So I think there was lots of evidence that eventually everybody would sign on, which is what's happening.
I think that's great. Is there equal sort of distribution of the providers in different areas? You know, are they located where they're needed?
Great question, Tiffany. Great question. So our research is looking at the entire province. British Columbia is massive, with a huge northern area, which is very difficult to access. The interior is rugged and mountainous. And in some of those rural and northern areas, it's much, much more difficult to access childcare. In Vancouver, where I live, big urban center, there are many spots. So it really, they're trying to roll it out across the province in a way that really does attend to those things. But right now it is differentially provided for sure.
Okay. Does anyone have any other comments or questions?
May I ask a question? You mentioned that this involved a community action research approach. Is that
yes?
Right? Methodically, what were the challenges of working with this population?
That's an interesting question. I have a real commitment to participatory action research. It's the only way in which I mostly do my research. So challenges, we took quite a lot of time and care to recruit our peer researchers. So that kind of slows down the research process for sure. And then we spent many, many hours training them to do good quality interviews. We had them interview each other. We interviewed them. We spent lots of time on kind of practice sessions. So they became quite adept. Their experience, of course, guides them in the right direction. You know, they come to the interviews with the strong feelings about what needs to be understood. So that does help quite a lot. And there's a trust component that kind of gets built quite quickly between them and the women that they're interviewing. So that's a plus. And this is an activist research piece, so that we do hope that we will use our findings to influence the province around some of the questions that you were asking, Tiffany, in terms of ensuring that there really is our services in some of the more remote areas. So the women are very excited, the peer research is very excited about kind of making deputations to the province, you know, speaking to cabinet ministers, etc. So the biggest detriment to peer research or to participatory action research, as far as I'm concerned, is it does slow things down, for sure.
Thank you. Well, we are at the end of our time. Thank you all for your very interesting talks. And I hope you have a good rest of the conference and the rest of your day or evening or morning, however, wherever you are. It was really nice to meet you and to be in a session with you.
Yes, thank you very much, Tiffany. Thank you for your excellent sharing, and It was a pleasure. Thank you. It was great to meet everybody.
Thanks all.
Thank you all.
Bye.
Take care. Bye-bye.
Yeah, bye.